It's a good afternoon on this Friday. Growing up, Friday the 13th used to be a very scary day, but I can assure you I've got good news today. Presenting on a topic on mental health, it's okay to not be okay in HIV care. The setting in Zimbabwe in 2017, the government already passed a policy that ensured that all people living with HIV in care were screened at least once a year for mental health. But interestingly, in spite of that policy being in place, we had a scenario where basically there was a blank cascade. You only have got the first column of the people who are living with HIV in care, but all the other columns have got blanks because of lack of implementation fidelity. And because of that, we had the world-renowned friendship bench coming together with OFID, working with the Ministry of Health to have an interdisciplinary collaboration towards improving the offering of mental health care within health facilities. And this is the results that we got from that activity, which we did in Chitungwiza in Zimbabwe. We had basically 4 facilities involved in this, and 14,000 clients were available at these facilities. Of those, 80% were assessed for mental health care using a simple tool, the famous PHQ tool, screening tool. And after they are assessed, they are immediately referred to the mental health assessment bench, which is the friendship bench. And you can see that 4% of those that turned positive on the PHQ screen were then referred to the friendship bench. And of those, most of them did manage to get the screening to establish if they had depression or not. And I want you to notice that though the algorithm for the mental health care requires one to have at least 3 sessions, because of the timing of this, only 42% did manage to get at least 1 session. And notably, 72% already demonstrated a reduction in their score, which is quite remarkable. And from this, we can safely conclude that mental health care can be provided in routine HIV services and at community level using community cadres. Those 2 ladies there, one is a community HIV care agent, and the other one is a grandmother from the from the friendship bench. And as this collaboration, we are looking at opportunities to further expand this both within the Ministry of Health in Zimbabwe, but also even beyond the borders, so that within HIV care, mental health is seamlessly integrated and people are able to access this much needed care. Thank you, ladies and gentlemen.
Thank you.
Good afternoon, everyone. I'll be presenting on factors associated with low TB case notification and treatment success in health facilities of Zambia. So, as we all know, TB is a global pandemic that affects mostly low-middle-income countries, particularly those in sub-Saharan Africa. But despite this being a challenge, we still have challenges in terms of detecting TB and also putting people who are infected with TB on treatment. So this particular study was done in 81 health facilities, and with the aim of determining what are the factors associated with low TB case notification, as well as their variations, so at which level of these different associations is the challenge. So we used secondary data from the Health Management Information System from 2017 and 2018, as well as the Health Facility Survey, which was conducted in Zambia in 2019. And for the analysis component, we used linear regression analysis, quantile regression analysis, as well as principal component analysis to help us understand these variations in association. And as I mentioned earlier, this study was done in 81 health facilities, mostly TB diagnostic centers across Zambia. and these were done in 18 districts. So in terms of TB case notification and treatment success, we can see that from the 2 years that were sampled, we still see low cases of TB being notified, particularly in 2018. I think if you see the graphs being shown, there was a variation between 2017 and 2018 in terms of treatment success itself, as well as TB case notification. And I think it's also important to see that the highest notifications are done in Lusaka district, which is the provincial capital of Zambia, whereas the other districts that are more remote, more rural, are not notifying and treating TB cases. So in terms of factors associated with low TB case notification, we see that personnel and also having no TB clinics were significantly associated with low TB case notification, as well as rural health clinics. This was similar with the case in terms of treatment success coverage as well. So some of the recommendations I would give is to increase TB case notification centers in rural districts, particularly those that are away from the provincial capital, as well as increase other diagnostic processes, which would include procuring more equipment in these rural communities in order to effectively detect TB. And also, I think in Zambia we have the test and treat policy for HIV, so having that also implemented at in TB communities would also effectively help increase the detection and treatment of TB. So my acknowledgements to Johns Hopkins University for sponsoring the study, the University of Zambia, and of course the Center for Infectious Disease Research in Zambia, where I come from. Thank you so much.
Good morning. I'm happy to be here to share with you some of the work I did during my master's in internal medicine. So I'm presenting immunological phases of sepsis in a population with significant HIV infection. So there are different phases of sepsis, and monocytes have been suggested to represent the different phases of sepsis. However, most of these studies, they excluded HIV positive patients when they were giving the different categories of sepsis. But in Uganda, HIV positive patients with sepsis, if you have a sepsis population, up to at least 40 to 50% are HIV positive. So this is just to show you, yes. So the objective was to determine the monocyte HLA-DR levels among patients with sepsis and healthy participants, and then to determine the interleukin-1 receptor alpha antagonist levels to confirm if really they're in sepsis. And it was a prospective observational study with 2 populations, and that was the flow cytometry gating strategy. So in the results, I found that 40% of the patients had HIV co-infection. As expected, healthy participants had higher monocyte HLA-DR than patients with sepsis. However, what I didn't expect to find was that HIV-positive patients with sepsis had higher monocyte HLA-DR than HIV-negative patients. And again, not expected, I found only 12% of people in moderate immune suppression. And this was confirmed that the patients in moderate immune suppression actually had higher interleukin-1 receptor antagonist. However, none of them was HIV positive. Therefore, I suggest that even as the care of sepsis moves towards personalized medicine, where everybody has specific immune state and you give them the biologicals that are needed, it is important that we do not forget the HIV positive patients, and we also give markers for them. I acknowledge Gilead, MUI Plus, African Research Collaboration of Sepsis, Macquarie, and IDI. Thank you.
Good afternoon, everyone. My name is Bonolo, Phinius, and I'm here to describe or talk about an atypical hepatitis B virus serology profile, which is characterized by a surface antigen positive test and a core antibody negative result. So essentially we know that hepatitis B virus serology profiles can come in different combinations that can actually mean different interpretations. But we do expect an individual testing positive for the surface antigen to also test positive for the core antibody rather. However, we have seen a description of some patients in several case studies that actually talk about individuals testing positive for the surface antigen, however, negative for the core antibody. Therefore, we aim to determine the prevalence of such an atypical profile in a cohort of people living with, HIV in Botswana. So out of the 271 surface antigen positive individuals identified in this cohort, we managed to screen 221 of them for the core antibody. And we saw that 12% of this cohort were people that carried this atypical profile. We also now looked at the participant demographics and the clinical outcomes, and we actually realized that these participants that carry this atypical profile were more likely to be female and younger. We still don't know what that could mean, but future studies would reveal this outcome. However, when we look at other participant demographics like CD4 T cell count, there wasn't any statistically significant difference. So essentially, this prevalence of this atypical phenotype is quite high. We say it's quite high because it's really not reported or discussed about. And we see that, or rather we should caution against HPV testing algorithms, particularly in some research institutions or in some research settings where samples that are positive for core antibody are the ones that are actually considered for surface antigen testing because it can actually underestimate HPV burden in those settings. This atypical phenotype has been associated with immune suppression. We didn't see that in our study. However, we are planning to sequence some of these samples to actually see if there are core or rather mutations in the core region that could be causing this atypical phenotype. With that, I'd like to acknowledge my mentors, my supervisors, my funders, and the Interest 2022 organizers. Thank you.